Okay, moving on, talking about specific desires now. We're going to start with the disorders of desire and arousal. So, desire first. And the first thing I want to point out is it may or may not be a disorder. So, it depends on whether it's bothersome to the person or causing trouble in their relationships. If they're not interested in being sexually active and it's not bothering them, then that's more asexuality, just not being particularly interested in sex, right? But if it bothers them or causes trouble in their relationships, then we could classify it as a disorder and call it hypoactive, which means underactive sexual desire disorder, which is kind of a mouthful, but there you have it, right? So I love this poster. It's not that you're not sexy, it's just that I don't care, right? So um, asexuality is often misunderstood as a sexual orientation. And so it's important to kind of bust some of those myths, right? It's not because they're abstinent because of a bad relationship or religious reasons necessarily, or that they're really repressed and uptight. It's not that they're afraid of being intimate with people or that they can't find a partner, right? And so people who identify as asexual still can engage in romantic relationships and they can still fall in love and they still can be sexually active, right? So that just because they aren't particularly interested in it doesn't mean that they don't ever do it. So they may choose to engage in sexual activity or not, right? So just be aware. So again, this is just the text kind of explaining that whether it's bothersome to them or not is what would cause us to classify it as a disorder or not. And so I find this really fascinating because in the United States, we do socially, culturally tend to place a lot of value and expectation about people having sexual desire and people wanting to have sex. And we assume that everybody should just naturally have a high libido or be interested in sex a lot, if not all of the time. And so the degree to which you internalize those messages may impact whether or not you find a lack of desire in yourself to be problematic or not, right? Of course, if you're in a relationship and if your lack of desire ends up causing difficulty in that relationship because perhaps the other person wants to be more sexually active than you do, then that could be a source of friction and difficulty as well. So this is pretty common in female-bodied people, but can happen in male-bodied people too, right? So this lack of interest in sex. So about a third of women-identified people and about a little more than 15%. And as you might remember when we talked about Helen Singer Kaplan and her three-stage model, disorders of desire are generally the hardest to treat because there are a lot of complicated psychological factors that play into this, as well as potentially some biologic and hormonal ones. So it's really, really tricky. And so there's been a lot of interest in the pharmaceutical industry to try to come up with a magic pill that would solve the problem of hypoactive sexual desire disorder, especially in female-bodied people. And a few years ago, they were really excited because they got FDA approval for just such a medication. So this medicine is called Adi or flibanserin for female hypoactive sexual desire disorder. And so the way this medication works is you have to take it every single day at bedtime. And the measure that they looked at was the number of sexually satisfying events per month, or so SSEs. And they found that people who took the drug versus people who took placebo had anywhere from a half to one on average more sexually satisfying event per month. But it's really interesting because the people who were treated with placebo also had an improvement, which is not uncommon, especially for something that has psychological factors. And so if you look at the difference between the two, which is what we're seeing in this chart here, so the placebo folks, which is the lowest line, their sexually satisfying events went up from baseline. So they just compared it to baseline. And so it happened to be from an average of 3 sexually satisfying events per month to anywhere from 3.5 to 4 in the placebo group. And it went up to 4.5 per month in the group that took the drug. So the upper lines are 2 different doses of the drug. Overall, that's when you averaged everybody together. But when they looked at all the women who took this medication, 10% more women in the drug group reported an improvement than in the placebo group. So right, not everybody had improvement. And this medicine is not without side effects, right? So it can cause sleepiness, dizziness, low blood pressure, and fainting to the point to where you can't drink any alcohol if you're taking this medicine. And this medicine, you have to take it every single day, whether or not you're planning on trying to have sex that night or not. So as you can see, the efficacy of this medicine is small, right? And the potential cost in terms of side effects and other impairments on your quality of life, if perhaps you like to have a glass of wine with dinner when you go out on a date, or stay in for a date in the age of COVID, right? So when this medicine first came out, they were like, oh, it's the female Viagra. It's going to revolutionize, the sex lives of women everywhere. So first of all, this is treating a disorder of desire, not arousal. Viagra treats a disorder of arousal, which we'll talk about next. And it's not very effective, and it has a lot of side effects, and it's really pricey. So this drug costs $760 for 1 month worth, right? So that's $760 for one more sexually satisfying event per month. I don't know. I think I could do more things with $760 that might make my life better. I don't know, right? So a disappointment surely for the pharmaceutical industry and their stockholders. So moving into disorders of arousal now. So we did the desire phase. Now we're going to talk about arousal itself, which is the excitement and plateau phases in the Masters and Johnson. So in male-bodied people, right, we're talking about erectile dysfunction, inability to achieve or maintain an erection sufficient for penetration and through to orgasm, right? So can't achieve it or can't maintain it. And there's different types. So perhaps if this has been something that's going on for someone's entire life, ever since they were a teenage boy, then we have to think, well, gosh, maybe there's something off with their physical anatomy, right? Something's off with the plumbing, something isn't working, maybe the nerves aren't hooked up right. So we would look for a physical cause. That's really rare. Usually we have what's called acquired erectile dysfunction. Things used to be working fine and now they're not. We also will ask about whether it's generalized or situational, right? So this is the kind of thing where, oh, you're fine when you're masturbating, but you're not fine when you're with your partner, for example. So that would be, if it's all the time, that's generalized. If it's just in certain situations, that would be situational. Another thing that we look at to kind of get an idea of whether the plumbing is working, and the wiring and all that kind of stuff is working, is this phenomenon of nocturnal penile tumescence. So during normal sleep, the penis will periodically become erect several times during the night. At certain points in your sleep cycle, you get an erection and then it goes away. You get an erection, it goes away. It usually happens several times during the night. So if that is still happening, right, then we know that things can work and that we need to look more at kind of psychological factors rather than physiological or physical causes of the erectile dysfunction. Back in the olden days, what we used to do is something called the stamp test. So stamps used to be sold. These were the lick kind of stamps, and they were sold on a roll, and they had these little perforations between them. And so we would have somebody tear off a line of stamps, lick them, and stick them onto the penis. And then if the penis got erect during the night and it enlarged, it would break the perforations between those stamps. And so we would know that they actually had an erection during the night. They don't sell stamps like that anymore, so I don't know what they do now. All right, so what are the common causes of erectile dysfunction? So certainly medical conditions can do this. So anything that impairs the ability to get extra blood flow to the penis can cause this, or that damages the nerves to the penis can cause this. So things like diabetes, atherosclerosis, which is hardening of the arteries, and neurologic problems can definitely cause erectile dysfunction. But these are things that affect older men, right? So definitely over age 50, and they're really rare in college students. So what are the things that we see in college students as causing erectile dysfunction? Certainly medications can do it. Antidepressants are very well known for this as a side effect. So a lot of times we, risk benefit, we decide it's worth it because we need to treat someone's anxiety or depression. That's causing them more suffering than problems with their sex life. So, but it's definitely a well-known side effect of the most commonly used antidepressants. Some high blood pressure medicines can do this too by decreasing the ability to get more blood flow into certain regions. We also find that alcohol in large doses absolutely can cause erectile dysfunction. This has been well known for hundreds of years. So Shakespeare, even his porter at the door in the play Macbeth, talks about alcohol and says it provokes the desire, but it taketh away the performance, right? So alcohol absolutely, marijuana can, and sometimes some other drugs can also cause erectile dysfunction. And then there are the psychological causes, right? So performance anxiety, worrying about if you're going to be able to perform up to expectation, stress, fatigue, guilt, shame, fear that somebody's going to walk in on you, all of those things can contribute to erectile dysfunction. There's also some evidence to suggest that pornography may be a bit of a problem here as well. So we're going to talk about that specifically. So we definitely seem to be seeing an increase in erectile dysfunction in young men, a group that, by and large usually doesn't have much of a problem with erectile dysfunction. And what we find is that there's a really strong correlation or association between erectile dysfunction and high consumption of online pornography. And so some people have started to study this, and what they find is that online pornography in many ways behaves on the brain similar to heroin, like an addictive substance. It stimulates the dopamine centers in the brain, and like other addictive substances, we find that people tend to need more and more and more to get the same effect. So if you're a lifelong heroin user, what happens over time is you need a higher dose and a higher dose and a higher dose. And so with pornography, that means, generally kind of more hardcore porn, and things can get really quite disturbing pretty quickly, right? So you get very far divorced from the reality of what a real life sexual encounter might be like. And so what we find happening is it seems like real life sex and real life partners now are boring. They're too low a dose of excitement and stimulation. They're not edgy enough, and people can actually have trouble with sexual function in real life because of excessive consumption of online pornography. This is a really fascinating phenomenon. We're still trying to learn about it. And it seems like it's not just a psychological phenomenon, that it actually also is rewiring the brain. So, we talked about that nocturnal penile tumescence that typically happens. A lot of these men that we're seeing with erectile dysfunction that seems to be associated to high porn use, they lose this, right? So like normally other psychological causes of erectile dysfunction, they still have erections at night while they're sleeping. But in the guys who've been consuming a lot of porn or really hardcore porn, they start to lose, it's almost like they've kind of burned out their ability to be sexual. What's really encouraging about this, however, it seems to be reversible. So what a lot of the psychologists who are treating this find is that after a 6 to 8 weeks, so 2 months, period of abstinence, the dopamine centers seem to return to normal and function starts to recover again. But interestingly, a lot of these men during this period of abstinence kind of go through a withdrawal. So they report, depression, anxiety, sometimes even physical symptoms, sweating, nausea, feeling really unwell. due to the decreased dopamine levels because they're not getting that stimulation anymore. So one of your media assignments is this video and article about pornography-associated erectile dysfunction. So I think it's a really important thing that we aren't really talking about publicly, and could have a huge impact on your generation just because of the high consumption of pornography that we know is happening, at least in certain groups of the community. All right, so how do we treat erectile dysfunction? So you want to correct the underlying problem. So if it's a pornography associated problem, stop watching porn, which is sometimes easier said than done, right? Habits are hard to break too. There are some behavioral techniques for performance anxiety, and those are in the book. So I encourage you to read up on those. I'm not going to hold you responsible for that. There are medical treatments available to treat erectile dysfunction, and basically they end up increasing the amount of a certain enzyme called cyclic AMP that is what encourages increased blood flow into the penis to cause the erection. Now, since the ability to physically do that is not generally the cause in young people, we don't typically use those medications like Viagra in young people, although sometimes if they just have developed a lot of performance anxiety and now they kind of have a hang up about it, sometimes we'll use those medicines to help get them over the hump and to take away that worry. You can also get shots into the penis. And then there are these biomedical devices. So the black and white image in the middle is a vacuum pump. So you basically pump it up and that creates a vacuum and it pulls blood into the penis to fill those erectile tissues, the corpora cavernosa and corpus spongiosum. And then the one that my head is in the way of, and I realized that although it looks to me like I make my head go away, I don't. And so I apologize. But so check the PDF of the slides to see this picture. There are these pumps where they put these little like hydraulic cylinders in the penis and then a reservoir of saline and a little battery pack pump with a switch in the scrotum so they can like and then right, and they get their erection. Then when they're done, they hit another button. So it's pretty amazing what's out there to treat erectile dysfunction. All right, what about female arousal disorder, right? So in this case, we're talking about someone with your normal desire, but they're not having those physical responses that we would normally expect to see in the vasocongestive phase, that increased blood flow, that vasocongestion that leads to kind of a throbbing or a fullness sensation, the vaginal lubrication. So there's lots of different causes and they can vary widely. So certainly there are psychological contributors here. If you're afraid or anxious or feeling guilty or shameful about what you're doing, that certainly gets in the way of your physical response. Sometimes it's poor stimulation from the partner, right? Maybe what they're doing just isn't actually feeling good. And so that's certainly a place where we need to work on communication and advocacy for yourself to communicate your needs and your wants. And sometimes there's some medical things. So low estrogen, which can happen after menopause for sure, or with some certain types of birth control. So that's something to keep an eye out for. And medications again. So those antidepressants can cause arousal problems in both male-bodied and female-bodied people. So the treatment address the underlying problem. Obviously, sometimes education and communication can go a really long way. Couples therapy sometimes, and sex therapy. And then lubricants, right? So if the part of the problem is a lack of vaginal lubrication, we actually have very many commercially available lubricants that can help. And sometimes once you kind of get things going, then things kick into gear. So lubricants are sometimes needed for vaginal sex, depending on whether there's an arousal disorder or depending on, just what kind of mood they're in, where they're at in their menstrual cycle, what type of birth control they're on. Lots of things impact the amount of lubrication the female-bodied person has inside the vagina from person to person and over time. And of course, remember that lubricants are always needed for anal sex because the anus doesn't have any natural lubrication to speak of. So a couple of general rules about lubricant. One is if you're not sure if you're going to need it or not, just go ahead and use it. So if you've ever had times where just like, oh, things were too dry and it wasn't comfortable, just go and have lubricant. And if you end up with too much and things are too slippery, well, that's an okay problem to have, and you can always dry some of it off. But you want to be careful to avoid that spectatoring, right? And be like, oh my gosh, am I going to get lubricated enough? And then you're stressed out about something, and that can interfere with the sexual response cycle. So when in doubt, just use it. Just take the question off the table. Just use it. There are some really inexpensive lubricants, and they will work well for a lot of people, but not necessarily for everyone. So KY jelly is kind of the famous one. It's very inexpensive. Most people will do just fine with it, but it has some things in it that allow it to be so inexpensive that sometimes can cause irritation in some people. So it's not always going to be the best bet, but it's always a great first go-to, and you can see if it works well for you. So we're going to talk about the different categories of lubricant, because I think this is important to know, and you probably won't learn it anywhere else. So there's kind of three main categories of things that are used as lubricant. So there's water-based lubes, silicone-based, and oil-based. And I'm going to talk about oil-based first because they aren't usually commercially sold. These are usually somebody breaks out the olive oil or the Crisco or something like, or the baby oil or the mineral oil to use as a lubricant. And that's certainly very inexpensive. It's very long lasting. But there's a couple of things about oil-based lubricant that you need to keep in mind. One is it's not compatible with latex. It will break down and degrade latex over time. So if you're using a latex condom, the likelihood that it could break goes up significantly if you're using an oil-based lube. So for that reason, they aren't generally recommended. Also, they're not perfectly ideal for vaginal use because the body can't really flush it out very well. It's not necessarily going to be harmful, but some people just don't like the fact that it just kind of stays there. Okay, so up to water-based. So the nice thing about water-based lubricants is that they're totally latex compatible, and they're great for vaginal use because the body can break them down because they're water-based, so they don't stick around forever. The less expensive water-based lubricants tend to use glycerin as their agent to make them slippery. And so that usually works really well for most people. Glycerin is technically a type of a sugar molecule, and in some female-bodied people, it can predispose them to getting yeast infections. So if there's somebody who's had trouble with yeast infections, then we recommend they kind of avoid the glycerin-based lubes or try them and just have a really low threshold to say, no, I don't think that's going to work. So without glycerin, it's a little bit harder to find something that's water-based and really slippery. So you're going to be looking at some slightly more expensive lubricants. So Sliquid makes a whole bunch of different water-based lubricants that don't have glycerin or any parabens, which interestingly are endocrine disruptors. So that's one brand out there. There are many others. The second category is silicone-based lubricants. Now, silicone is a great material. It's really slippery. It's got a nice, thick, velvety feel to it. It's really long-lasting, and it's completely latex compatible. It's not necessarily ideal for vaginal sex, again, however, because the body has no way to get rid of it. It just stays there forever, which in some ways you might be like, well, bonus, because then we won't need to use any tomorrow because it'll still be there. Yes, but sometimes people just kind of just don't like that idea. Does it cause problems sitting around in the vagina? Not really. And there are some lubes that are formulated specifically for vaginal use where they try to use a little bit of the water-based and a little bit of the silicone, so kind of a lower level of silicone. So that's something you can try. Another point I want to make is that if you're using a silicone-based lube, you need to be careful if you're using any sex toys that are also made out of silicone. So the rule in chemistry is that like dissolves like. And so anytime you're using any type of sex toy, if you are at any point in your life, you just want to find out what kind of material it's made out of and what lubricants it is and is not compatible with. Because sometimes you can spend a lot of money on those things and you don't want them to start kind of dissolving or melting because you used a lube that wasn't compatible. So there's a great online resource. I own no stock in them, but goodvibes.com is a store that sells all kinds of things. But they have one of the best lube selections out there, and they have helpful folks if you want to call and talk to them. All right, so for our disorders of arousal, then we talked about erectile dysfunction, which in younger men is typically due to alcohol, drugs, or medications such as antidepressants, or possibly even pornography use. And the female arousal disorder, right, which is a lack of that physical response. And so we talked about the different types of lubricants and the importance of using it when appropriate. We also, in this lecture section, talked about the disorders of desire, and how it may or may not be a disorder depending on whether it bothers the person. All right, so the next section is our last, talking about pain disorders and orgasmic disorders.